Welcome to the deep dive. Today we're tackling a really important health issue, one that many people with diabetes face. Diabetic foot ulcers, or DFUs as they're often called.
Exactly.
A listener actually asked us to dig into this, and we've got some great material. We're using chapters from Hyperbaric Medicine Practice, specifically Chapter 22, which is all about evaluating and managing these ulcers.
Right. And for you, the learner, our goal in this deep dive is really to pull out the critical insights on DFUs. We want to give you a clear, digestible understanding of, what causes them, how doctors assess them, and the different ways they're treated.
Kind of a shortcut to getting informed on a complex topic.
Precisely. Think of it like that.
Yeah.
Getting the essentials without wading through everything.
And it is a huge problem. I mean, the number of people with diabetes globally is just massive.
It really is.
Just in the U.S., think back to 2012, almost 29 million adults had diabetes. And that number had, quadrupled between 1980 and 2014?
Quadrupled, yeah. Globally, the estimate is around 422 million adults. It's an epidemic.
Okay, so let's unpack this a bit. A major issue with diabetes is the end organ damage it can cause.
Right.
Things like peripheral neuropathy, that's nerve damage, and peripheral arterial disease, PAD, which affects blood flow.
And those two are major players when it comes to lower extremity ulcers. They can lead straight to them, and sometimes, unfortunately, limb loss.
What's really striking is how common this complication is.
Yeah, the numbers are sobering. It's estimated that at least 15% of people with diabetes will develop a foot ulcer sometime in their life.
15%. Wow.
And every year, the incidence is something like 5% to 6%. So it's an ongoing issue.
Which you have to imagine comes with a massive financial cost.
Oh, absolutely. No kidding.
Yeah.
In 2012, the total cost tied to diabetes in the U.S. was estimated at, $245 billion?
Staggering.
And even back in 2001, just the DFU treatment and amputations cost around $11 billion.
And for individuals, I read that Medicare folks with a foot ulcer can have healthcare costs 3 times higher than diabetics without one.
That's right. 3 times higher. But, beyond the money, the human cost is immense.
Absolutely.
If you develop a foot ulcer as a diabetic, you're at a really high risk of it not healing, potentially needing a major amputation, we're talking above the ankle, and sadly, even increased risk of death.
It's serious. I saw a statistic that something like 60% of non-traumatic lower limb amputations in the U.S. happen in people with diabetes.
That's the figure. And the mortality rates linked to these ulcers and the amputations that might follow, they're alarmingly high. Comparable to some cancers, actually.
So a key insight there is that this isn't just a local wound. It has potentially devastating systemic consequences.
Exactly. It really underscores why this is such a critical area in healthcare.
And why you see these multidisciplinary teams getting involved, right? With really detailed care plans.
Yes, that's essential. Because even with the best standard care cleaning, offloading pressure, good dressings healing can still be a real challenge.
Which brings us to the core question. Why? Why are these ulcers so difficult?
Well, the fundamental issue is that a DFU isn't just a simple cut. It's the result of dysfunction across multiple organ systems, all stemming from that persistently high blood sugar hyperglycemia.
It's like a domino effect starting from high sugar levels.
Precisely. We can't cover every single mechanism, obviously, but there are key processes that are crucial to grasp.
Okay, let's get into that. How does the body react to high blood sugar in ways that cause these foot problems? It seems to go right down to the cellular level.
It does. Certain cells, like the ones lining our tiniest blood vessels, the capillary endothelial cells and nerve cells, they kind of struggle to regulate how much glucose they take in when blood sugar's high.
And that misregulation kicks off other problems.
Exactly. It starts a chain reaction. For instance, diabetes is strongly linked to issues in both the big blood vessel, that's microvascular disease, leading to things like heart attacks, strokes, critical limb ischemia, and also the tiny blood vessels, the microvasculature.
And that's where wound healing comes in.
Yes, the microvascular disease is key here. It impairs the delivery of oxygen and nutrients needed for healing. High blood sugar increases harmful molecules called reactive oxygen species, ROS.
ROS, right.
These ROS interfere with nitric oxide production. Nitric oxide normally helps blood vessels relax. So less nitric oxide means vessels constrict, reducing blood flow.
Making it harder for oxygen to get through.
Exactly. Plus, the capillary walls can thicken, further blocking oxygen diffusion. And on top of that, the autonomic nerves that help control blood flow can be damaged by neuropathy, so the body doesn't respond properly with increased blood flow when there's an injury.
It's a cascade of issues all hindering that crucial oxygen supply.
Precisely. And speaking of neuropathy, Nerve damage is absolutely central to DFU development.
In several ways, right? Sensory, motor, autonomic.
Yes, all three. And each type significantly boosts the ulcer risk. You could say neuropathy creates this sort of perfect storm for DFUs by messing with protection, causing deformities, and damaging the skin.
Okay, let's break those down. Sensory neuropathy seems like the most obvious link.
It is. That loss of protective sensation, LOPS, means you just don't feel things.
Like a pebble in your shoe.
Exactly. Or pressure from poorly fitting shoes, friction, minor scrapes, things that would normally cause pain and make you react. You don't notice them until damage is done.
And it's kind of ironic, but people who already have nerve pain might be at even higher risk.
It sounds counterintuitive, but yes. That existing chronic pain can actually mask the acute pain of a new injury, like an ulcer starting.
Okay, what about motor neuropathy? How does that play in?
Well, historically, the thinking was that it weakens the small intrinsic muscles in the foot.
Letting the stronger leg muscles take over.
Kind of. The imbalance allows those stronger muscles to pull the foot into abnormal positions. Think claw toes, hammer toes.
Which changes how pressure is distributed on the foot.
Right. You get these high-pressure areas, especially on the balls of the feet or the tops of the toes. Combine that with the numbness from sensory neuropathy.
And you've got a recipe for an ulcer.
Exactly. Managing this often involves surgery to correct the shape or special shoes to offload that pressure. But if those underlying deformities aren't dealt with, ulcers are very likely to come back.
Even if they heal the first time.
Yes, recurrence is a big problem if the root cause isn't addressed.
And then there's Charcot arthropathy. That one sounds different. Weakening bones due to increased blood flow.
Yeah, it's a bit paradoxical. Autonomic nerve damage leads to dysregulated excessive blood flow to the bone. This, over time, weakens the bone structure.
Leading to fractures without major injury.
Correct. Microfractures, dislocations. Often without the person even realizing it happened. The foot's architecture can collapse, leading to that classic rocker bottom deformity.
Putting pressure on the midfoot.
Exactly, making ulcers in that area much more common. And a key insight here is that even too much blood flow, if it's uncontrolled due to nerve damage, can be destructive.
What are the signs of that early on?
In the acute phase, the foot might be hot, swollen, red. It can easily look like an infection.
So tricky to diagnose.
Very. Treatment early on is strict non-weight bearing, usually in a total contact cast. Later, it's about supportive devices like CRO boots or custom shoes. Sometimes surgery to smooth out bony prominences once things stabilize.
Early diagnosis is key.
Crucial. And related to this, many diabetics have restricted joint mobility because high sugar levels affect collagen. The stiffness can also increase plantar pressures and contribute to Achilles tendon problems.
Okay, last type of neuropathy. Autonomic. What does that do?
Autonomic neuropathy affects involuntary functions, including sweat glands. This leads to anhidrosis, basically. The skin on the feet becomes extremely dry, cracked, and calloused because it can't moisturize itself with sweat.
Creating entry points for bacteria.
Exactly. That dry, cracked skin is a breach in the body's defenses. Plus, the thick calluses increase pressure. Combine that with a lack of sensation. It's a dangerous mix.
So it compromises the skin's barrier function.
Precisely.
Beyond ulcers, are there other skin things to watch for in diabetes?
Yes. Several conditions, while not exclusive to diabetes, should raise suspicion if you see them. Things like diabetic dermopathy, those harmless brownish shin spots,
Okay.
or the rarer necrobiosis lipoitica diabeticorum, NLD, which looks like reddish-brown patches and can sometimes ulcerate. That can even show up before diabetes diagnosis.
Interesting. What else?
Diabetic bullous spontaneous blisters without injury, likely due to fragile tissue. Anhidrosis, the dry skin we mentioned. Nail discoloration could be fungal, but worth thinking about diabetes. Thickened nails might suggest poor perfusion, PAD, and even granuloma annulare, raised rings on the skin, seem more common.
Lots of potential skin clues. Now, infections, you mentioned, those are a major worry.
Huge worry. Fungal infections, like athlete's foot or nail fungus, are super common. They might seem minor, but they damage the skin surface.
Creating that entryway we talked about.
Exactly, making it much easier for bacteria to get in and cause cellulitis or deeper infections. Research actually shows fungal foot infection is a significant risk factor for bacterial infections.
So treating even minor fungus is important.
Very important. And bacterial infections themselves are a serious threat in the diabetic foot.
What kind of bacteria are we usually talking about?
Often it's aerobic gram-positive Kochei, like Staph aureus. But in chronic wounds, or if someone's had antibiotics before, you might see gram-negative bacteria too. If there's gangrene or ischemia, Anaerobic bacteria can be involved.
How are these diagnosed? Mostly by looking at it.
Diagnosis is largely clinical redness, warmth, swelling, pus, pain. But getting a culture is really important, especially if you suspect osteomyelitis, the bone infection.
And how should those cultures be taken?
Ideally before starting antibiotics. And a tissue biopsy, curettage scraping, or fluid aspiration is much better than a simple surface swab, which often just grows surface contaminants.
Okay. And imaging.
Imaging, especially MRI, is great for seeing soft tissue infections and suspected osteomyelitis.
What about antibiotics? Always needed.
No, definitely not for uninfected wounds. But if there is infection, you typically start empiric therapy based on the likely culprits and severity, then adjust based on culture results.
How long is treatment usually?
Depends on severity. Maybe 1-2 weeks for mild skin infections, 2-4 for moderate or severe, and often 4-6 weeks or even longer for osteomyelitis.
And a bone biopsy is key for osteomyelitis.
Very valuable, yes. Confirms the diagnosis and helps pick the right antibiotics.
Okay, finally, back to the cellular level. We mentioned ROS and lack of oxygen, hypoxia.
Right, that hypoxia really hampers healing. For example, fibroblasts, the cells that make collagen for tissue repair, their activity is reduced by age anyway, but even more so in diabetes. So healing slows down.
And immune cells.
Immune cells like neutrophils, which fight bacteria, rely on oxygen for their respiratory burst mechanism to kill germs. In the low oxygen environment common in diabetic tissues, their ability to fight infection is impaired. They need sufficient oxygen to work properly.
So with all that complex pathophysiology, examining someone with a DFU must involve more than just looking at the hole in their foot.
Absolutely. A really comprehensive evaluation is crucial to understand why this ulcer is there and what needs to be addressed. It starts with a good history.
Asking about pain, when it started, previous ulcers.
Exactly. And how it started, was there obvious trauma or did it just appear? Recurrent ulcers, especially if they keep coming back despite non-surgical treatment, might point towards needing something more aggressive for an underlying deformity.
And spontaneous ulcers are more worrying.
Often, yes. They suggest a more significant underlying issue compared to one clearly caused by, say, stepping on something sharp.
Then the physical exam, and you mentioned looking at both feet.
Always examine both feet. Look for deformities, previous surgery sites, signs of trouble on the other foot too. It gives you the bigger picture and helps anticipate future problems.
And specific tests during the exam, like the monofilament.
Yes, the Semmes-Weinstein monofilament exam is standard, using that 5.0710 gram filament.
The one that bends at a specific pressure.
Right. You touch it to specific points on the sole great toe, third and fifth metatarsal heads are key spots, if the patient can't feel it.
That's LOPS, loss of protective sensation.
Correct. And that indicates a significantly higher risk for future ulcers and amputation. Anyone with a DFU needs this test. And if it's abnormal, patient education on foot care is critical.
What about other sensory tests?
Vibration testing with 128 Hz tuning fork on the big toe is another good one. Loss of vibration sense is abnormal. Pinprick sensation on the top of the big toe can also be checked.
Okay. Now, vascular assessment. You said this is vital but tricky.
Vital, yes, but interpretation can be complex in diabetics. And importantly, no single screening test perfectly identifies PAD. Abnormal results mean a referral to vascular surgery is needed.
What's the starting point? Feeling pulses.
Yes, palpating pulses, dorsalis pedis on top of the foot, posterior tibial behind the ankle bone, popliteal behind the knee, femoral in the groin, but
Palpable pulses don't rule out ischemia.
exactly. And absent pulses don't automatically mean critical limb ischemia. The accuracy for diagnosing PAD just by pulse palpation alone is only around 60% in diabetics without ulcers. Best done in a Warren room, too. Pulses are graded 0 to 4 plus key.
What about using a Doppler?
Definitely. You should auscultate the pedal pulses with a handheld 8 to 9 megahertz Doppler probe. Listening to the waveform tells you a lot.
Triphasic, biphasic, monophasic.
Right. Triphasic is generally good elastic arteries. Biphasic might show some early stiffening. Monophasic often suggests more significant PAD and warrants further investigation.
Then there's the ankle brachial index, ABI.
The ABI. Common, inexpensive screening tool. Compares ankle pressure to arm pressure using the Doppler and a cuff. Needs practice to do well, though.
And its accuracy can be lower in diabetics.
Yes, especially with neuropathy or existing ulcers. Calcified stiff arteries can give falsely high readings, but generally an ankle pressure under 80 mmHg suggests poor healing potential.
How is it interpreted?
Normal is roughly 0.91 to 1.3. Over 1.3 often means those incompressible calcified arteries. Between 0.41 and 0.90 suggests mild to moderate PAD. Below 0.4 is usually severe PA. An ABI of 0.90 or less is considered a good indicator for PA.
So guidelines recommend it as a first screen.
Yes, SVS guidelines suggest it for symptomatic PAD, and maybe an exercise ABI if someone has claudication symptoms, but a borderline or normal resting ABI. Just don't do it if you suspect a DET.
What about toe pressures, the toe brachial index, TBI?
TBI can be useful because toe arteries are often less calcified. An absolute toe pressure under 30 millimillis G is quite specific, though not super sensitive, for poor healing. A TBI ratio under 0.75 is a pretty good indicator of PAD in diabetics.
Are there more advanced tests, like skin perfusion pressure?
SPP, yes. Uses laser Doppler to measure microvascular flow in the skin. Below 30 millimillis G suggests poor healing potential. It actually seems to correlate better with outcomes after revascularization procedures than ABI does.
And measuring oxygen directly, TCPO2?
Transcutaneous oxygen measurement.
Yeah.
Below 30 millimillis G usually indicates critical limb ischemia. Some use a 25 millimillis G threshold for better sensitivity specificity. Interestingly, the room air TCPO2 doesn't predict response to hyperbaric oxygen. But if the TCPO2 goes above 200 millimillis G during hyperbaric oxygen treatment, that correlates well with high healing rates for DFUs.
And that newer fluorescence angiography.
ICFA, using indocyanine green dye. It lets you visualize the microvascular blood flow directly.
Yeah.
Helps identify ischemic areas, track improvement. Still working on definitive cutoff values for predicting healing, though.
So the takeaway is no single test is perfect.
Absolutely. You need to integrate the findings. The IWGDF group suggests SPP, toe pressures, and TCPO2 might be more useful than ABI in predicting healing. But low ankle pressure, or ABI, definitely flags higher amputation risk.
Okay, moving to imaging. When are x-rays useful?
Good baseline. Rule out foreign bodies, fractures. Repeat x-rays over time might show bony erosion suggesting osteomyelitis or Charcot changes, but their sensitivity and specificity for osteo aren't great.
MRI is better for bone infection.
Generally the test of choice for suspected osteomyelitis. High sensitivity and specificity can sometimes overestimate it, though.
And bone scans.
Less common now, but an option if MRI is contraindicated. Lower specificity than MRI, though adding a tagged leukocyte scan helps.
What about that probe to bone test, PTB?
The PTB. Simple bedside test, gently probing the ulcer base with a sterile, blunt instrument to feel for bone. It's been controversial.
Why controversial?
Concerns about technique variability, potential misuse. Studies show varying accuracy. Some suggest it's highly predictive, others less so.
So what's the consensus?
I'd say a positive PTB in a chronic DFU is suggestive of osteomyelitis, but a negative MRI makes osteo less likely if other signs are absent. No single finding rules it out reliably. Doctors often look for a combination. Ulcer size 2 centimeters sees positive PTB, high ESR, abnormal X-ray.
Got it. What about blood tests, lab studies?
A CBC, complete blood count, checks for infection signs like high white cells and also hemoglobin hematocrit for oxygen carrying capacity. Very low levels might impair oxygen delivery.
And HbA1c.
Hemoglobin A1c reflects long-term sugar control. Good control is always the goal, but there isn't strong evidence to deny needed DFU treatment just because the A1c is high. Patients can still heal.
I've heard of EG too, estimated average glucose.
Yeah, it's a conversion from A1C meant to be more patient-friendly. Formula exists, but its clinical utility is debated.
What about nutritional markers like albumin, prealbumin?
They were once thought to reflect nutritional status, but now we understand they're also negative acute phase reactants, meaning they can drop during inflammation or infection, making them unreliable nutrition markers in this context.
Okay. And inflammatory markers like ESR and CRP?
Erythrocyte sedimentation rate and C-reactive protein. They can be elevated with infection, including osteomyelitis. Probably more useful for monitoring response to treatment rather than initial diagnosis.
Okay, so we have all this information. How do we classify the ulcer itself? There seem to be many systems.
There are. Many classification scales exist, but a key issue is that few have been rigorously validated for predicting outcomes reliably. They often focus on anatomy, vascular status, infection.
But their practical use can be unclear.
Sometimes, yeah. Are they for research, auditing care, guiding clinical decisions? It varies.
Let's talk about the main ones. Wagner.
The Wagner classification is one of the oldest, from 81. 6 grades, 0 to 5, based mostly on depth and presence of infection or gangrene.
It's been criticized for ignoring blood flow.
It has, although Wagner himself did incorporate ABI assessment into his treatment approach. A limitation is that most DFUs fall into grade 2 or 3, so it lacks granularity.
But it's still used, especially in hyperbaric medicine.
That's the key point. It's the only system historically used in hyperbaric clinical trials, and crucially, it's linked to reimbursement in the U.S. CMS often requires a Wagner Grade 3 for HBO2 coverage after 30 days of standard care.
Which can lead to it being misapplied sometimes.
Potentially, yes, but generally a higher Wagner grade does correlate with increased risk of amputation and healing failure.
What about the University of Texas system, UT?
The UT system is a matrix. It combines depth, 4 grades, with the presence-absence of infection and ischemia, 4 stages. Creates 16 categories.
More descriptive than Wagner.
Generally considered so, yes. And studies show it's better associated with predicting healing and amputation risk. Higher grade and stage mean worse outcomes.
Any others focused on infection?
The IDSA Infectious Disease Society of America has a 4-grade system purely based on infection severity. Higher grades clearly correlate with more amputations.
And that PETA system.
From the IWGDF International Working Group on the Diabetic Foot, PETA stands for perfusion, extent size, depth, infection, sensation. More research-focused, less used day-to-day.
I saw mention of a Long Beach score.
Yes, the Long Beach Wound Score. A simpler 0-10 system trying to integrate key factors: appearance, size, depth, bioburden, perfusion to help with limb salvage decisions. Seems reliable between users, validation ongoing.
And WIFI from vascular surgeons.
Right, the Society for Vascular Surgery's WIFI score: wound, ischemia, foot infection. Each gets graded 0 to 3, making 32 permutations. Again, higher grades mean worse outcomes. Validated predictor of amputation and non-healing.
Finally, the Wound Healing Index, WHI. That sounded different.
It is. Developed from analyzing a huge wound registry database. It uses 10 factors: patient age, wound age, area, ambulatory status, infection, dialysis, Wagner grade, PVD, etc., to calculate a score predicting healing probability at presentation before treatment.
Needs electronic health records, though.
Yes, requires integrated EHRs. Could be the future trend for allocating resources, potentially.
Wow, so many systems. It really highlights the complexity.
It does, and some are genuinely useful for risk stratification, but others have kind of devolved into tools for justifying reimbursement. We still need better validated systems, especially for guiding advanced therapies.
Okay, so we've covered the what, why, and how of evaluating DFUs. Now, the crucial part, management. We know the risks are high amputation mortality.
Absolutely. And the cause can be neuropathic, neuroischemic, or purely ischemic. Given all the contributing factors, local and systemic, that multidisciplinary team approach is non-negotiable for success.
Who's typically on that team?
It can be broad. Wound specialists, primary care, endocrinologists, podiatrists, orthotists for footwear, vascular specialists, foot and ankle surgeons, infectious disease docs, hyperbaric physicians.
A whole village.
Pretty much. And having systematic evaluation and treatment algorithms is key for these limb salvage programs.
What's usually the first critical step, especially if PAD is involved?
Vascular intervention. If testing shows significant PAD, referral to vascular surgery or interventional radiology is essential for evaluation and potential revascularization, opening up those blocked arteries.
Either endovascularly or with open surgery.
Correct. Restoring adequate blood flow demonstrably improves healing and reduces amputation risk, even in less severe PA cases, not just critical limb ischemia. The WIFI score can help guide those decisions.
Another cornerstone seems to be offloading pressure.
Absolutely fundamental, especially for those plantar neuropathic ulcers.
Yeah.
And the evidence is pretty clear. Non-removable devices work best.
Like total contact casts, TCCs, or irremovable boots?
Exactly. Studies consistently show they lead to significantly higher healing rates compared to removable options that patients might take off. The Cochrane Review supports this.
What if a non-removable device isn't feasible?
Then a knee-high removable calf walker seems to be the next best thing among removable options. There's also something called a soft TCC. For non-plantar ulcers, you just need effective pressure relief specific to that site.
And prevention for those who've healed.
Custom-molded diabetic shoes fitted by a podorthist are crucial to prevent recurrence. The key insight: consistent, effective offloading is non-negotiable for neuropathic ulcers.
Okay, infection control. We know diabetics are prone to serious infections, maybe with fewer obvious signs.
Right, and infection is a top reason for amputation. Initial assessment often uses probe-to-bone and serial X-rays, MRI, or scans if needed, for deeper suspicion.
And treatment for osteomyelitis.
Primarily surgical debridement of infected bone, getting cultures plus antibiotics. Bone biopsy is highly recommended if initial cultures are unclear or treatment isn't working.
Is there agreement on the best antibiotic regimen?
Interestingly, no. Systematic reviews find limited high-quality evidence for specific DFI treatments. More trials are needed. No strong evidence for topical antiseptics either. For skin infections, different regimens seem roughly equivalent.
What about for osteo?
No definitive studies on the ideal regimen or duration. Some suggest surgery plus short-course antibiotics might equal long-course antibiotics alone. Oral versus parenteral routes seem similar. But getting that bone culture leads to better outcomes than just surface swabs.
Let's talk glycemic control. Intuitively, better sugar control should help healing, right?
You'd think so. And good control definitely reduces the risk of getting complications. But a 2016 Cochrane review found no solid RCT evidence proving tight control directly improves healing of existing DFUs.
But it does lower the risk of getting them or having them recur.
Yes, studies do show higher HbA1c increases risk of developing DFUs, and poorer control increases recurrence risk. It's complex. Proposals to limit treatments like HbO2 based on A1c are controversial, as patients with high sugar can still heal.
And super tight control has its own risks sometimes.
Yeah, exactly. Like the Accord study showed potential harm. Plus, psychological and socioeconomic factors heavily influence glycemic control. It requires ongoing support, sequential counseling, that team approach, again, PCP, endocrine, nutrition.
What about debridement, regularly cleaning out the wound?
Serial debridement is key. Removes dead tissue, lowers bacterial load, stimulates healing, should typically happen every 1 to 4 weeks.
Is one type of debridement better than another?
Evidence supports its general efficacy, but comparative effectiveness evidence is weaker, so the type is often up to the physician. Autolytic debridement seems to help. Larval therapy, maggots, has shown reduced amputation rates in some studies, but not consistently better healing rates. Surgical debridement might speed things up compared to basic care.
And local wound care, dressings.
Goal is a moist wound bed, managing exudate, avoiding maceration of surrounding skin. Optimal dressings help autolytic debridement prevent infections, support healing. Wet to dry is generally out.
Any specific dressing type proven superior? Hydrogels, foams?
Cochrane reviews haven't found a clear winner among hydrogels, hydrocolloids, foams, alginates. A recent meta-analysis hinted hydrogels might be better than basic dressings. Non-adherent dressings might be more cost-effective.
What about negative pressure wound therapy, NPWT?
Wound vacs, yeah. Often recommended if a DFU isn't improving much, less than 50% smaller, after 4-8 weeks of advanced dressings. An RCT showed faster healing, less home care needed, fewer secondary amputations with NPWT.
So tailor the dressing choice.
Exactly. Tailor it to the wound characteristics.
And if standard care isn't enough after a month or so, adjunctive therapies.
Yes, consider them if there's less than 50% improvement at 4 weeks. That includes NPWT, various biologics like topical growth factors, PDGF, skin substitutes from various sources, placental, porcine, cadaveric, human-derived.
Human neonatal foreskin products showed promise.
Yes, they showed increased healing in some tough-to-heal DFUs in studies. And hyperbaric oxygen therapy, HbO2, is another adjunctive option, discussed elsewhere in the source material. Split-thickness skin grafts are sometimes used, but evidence isn't strong for routine DFU use.
This all leads back to the multidisciplinary limb salvage team idea.
Precisely. Specialized centers focus on reducing amputations, improving quality of life, lowering costs. Evidence-based protocols, sometimes including HbO2, show high rates of limb salvage at 1 year, often with lower costs and mortality than primary amputation.
How do these teams approach it systematically?
Experienced clinicians use a stepwise approach. The Voids mnemonic helps summarize key components: vascular, offloading, infection control, diabetes control, surgical debridement.
In tracking progress.
Serial wound measurements are crucial. That 50% reduction in 4 weeks is often the trigger to consider adding adjunctive therapies.
Okay, so wrapping up this deep dive on diabetic foot ulcers,
Yeah.
we've certainly covered a lot.
We really have.
From the complex physiology and risks to the detailed exam and classification methods and the absolute necessity of that comprehensive team-based management. Hopefully you, the learner, have a much clearer picture now of why these wounds are so significant.
Yeah, why these seemingly small foot problems can have such massive systemic consequences. And with diabetes prevalence rising, understanding and managing DFUs effectively is just becoming more and more critical for individuals and for the healthcare system.
It's also good to see the ongoing research, right? Trying to refine classification, find better treatments. It shows a real commitment to improving outcomes and preventing limb loss.
Definitely. Which leaves us with a final thought, maybe something for you to consider.
Yeah.
Given all this complexity we've discussed, the pathophysiology, the patient factors, the different treatments, the team approach, What do you think is the single biggest hurdle to ensuring everyone at risk gets optimal DFU care?
Hmm.
Is it catching things early enough? Is it helping patients stick with demanding treatments like offloading? Is it access to those specialized teams? Or maybe something else entirely?
That's a really important question, one that researchers and clinicians are constantly grappling with in this vital area.